Dear viewers, good afternoon and please be welcome at this fourth seminar organized by the ERACODA Research Group on behalf of the European Renal Association. And this seminar, as you may know, is one out of a series dedicated to kidney-related aspects of COVID-19. And in this series of seminars, we are covering 4 topics. The first seminar was dedicated to the topic of chronic kidney disease patients and their risk for a severe course of COVID-19. It was in November 12. Second seminar was on COVID-19 causing acute kidney injury. Third seminar, practical COVID-19 related aspects of kidney replacement therapy. And these seminars you can look back at the website of the European Renal Association. Today we'll have the 4th seminar, and that has a different format. It has also a different type of title. It is all you want to know about COVID-19 vaccination of kidney patients. And it is organized by the ERACODA organization. And ERACODA is an acronym that stands for European Renal Association COVID-19 Database. It was established March 21 by the ERA-EDTA Council, and it consists of a REDCap database with prospective collection of granular data of patients on dialysis or living with a kidney transplant that developed COVID-19. The aims of this database is to investigate the clinical cause and outcomes of especially patients on kidney replacement therapy with COVID-19, and also to gain information on risk factors for mortality, because we hope that such information may guide clinical treatment decisions, support in the future triage strategies for admission, for instance, to intensive care units, but perhaps also lead to interventions. And by January 1 this year, we had individual level data of more than 3,000 patients with kidney failure and COVID-19, 70% of them being patients on dialysis and approximately 30% kidney transplant recipients. And these data have been entered by more than 200 physicians across Europe. Today's topic is different from previous seminars. This one is all you want to know about COVID-19 vaccination of kidney patients. And I realize that I haven't introduced myself yet. My name is Gansevoort. I'm from Groningen, the Netherlands. I'm one of the 2 moderators. I'm also one of the 2 people that started ERACODA. The co-chair will Professor Luuk Hilbrands, the other man that started the ERACODA organization. Today we will not have classical presentations, but we'll have a virtual roundtable. We'll answer questions that have been sent in by the public. And we have a couple of experts, and I'm very honored and glad that we have found these people willing to contribute to this virtual roundtable. And that is an immunologist and vaccination expert. That's Professor Marjolein van Egmond from Amsterdam, the Netherlands. We've got a patient's representative, Fiona from England, an expert on vaccination in chronic kidney disease and dialysis, Professor Piergiorgio Messa from Milan, an expert on vaccination in kidney transplantation, Professor Marta Crespo, and we've got a virologist and vaccination expert, Dr. Coretta van Leer from Groningen, the Netherlands. And before we start the roundtable, we decided that I would first have a couple of slides, 5-6 slides, to introduce the problem to you. And this slide shows you some important results of the ERACODA database, and it shows you the outcome of COVID-19 in patients with kidney failure. On the left, you see ICU admission, and on the right side, you see mortality. And the mortality at that time in ERACODA was for patients on dialysis 25%, and that's huge, as you will realize, and mortality in transplantation patients 21%. When you look at intensive care unit admission, you see a different picture. It are especially the patients with a transplant that are admitted to ICU and not patients on dialysis. So many patients on dialysis dying, but only very few of them admitted to an intensive care unit. And probably that's because people have a negative perspective on dialysis patients and their prognosis. And I don't think that's correct, because when you look at mortality, when you adjust for age and sex, because transplant patients often are younger, of course, transplant patients also have less comorbidity. When you adjust for that, actually transplant patients have a higher mortality than dialysis patients. So that's, for me, is the lesson, that we should not be too reluctant with admitting dialysis patients to intensive care units. So mortality is high, but how does it compare to other high-risk groups? And that is shown in this slide. It is a slide redrawn from a very important study by Williamson that was published in Nature. It reports on the Open Safely study and health analytics platform that covers 40% of the patients of the NHS in the United Kingdom. It includes 17 million people, and at that time 11,000 COVID-19 related deaths. And they looked at the fully adjusted hazard ratio for mortality, COVID-19 related mortality. And here in the bottom part, you see the classical risk factors for COVID-19 related mortality, like hypertension, obesity, chronic heart disease, diabetes, severe obesity, but also pulmonary disease. And here on the top, you see the kidney patients, patients with a GFR between 30 and 60, patients with a GFR below 30, patients on dialysis, and patients that are living with a transplant. And what you then see is that, especially in the group with very low kidney function on dialysis or living with a transplant, the hazard rate for mortality is huge. It is much higher even than the other more well-known risk factors for COVID-19 related mortality. So our population that we are caring for is a really high-risk population. So there is really a need for patients with chronic kidney disease, including those on dialysis and living with a transplant. There's a need for an effective and safe vaccine for COVID-19. And that's also the topic of today. Let me first then show you a slide how it actually works, more or less. This shows you a coronavirus particle, and it shows you a single-strand RNA, and that RNA is encapsulated by a nucleoside peptide, but also a layer around it with the envelope proteins, membrane proteins, and of course the well-known spike proteins. And these spike proteins are important. As you know, these are bind to the ACE2 receptor, and via binding of the spike protein to the ACE2 receptor, the virus enters the epithelium. And it does so in a kind of vesicle, and the virus then fuses with the vesicle. RNA is released in the cytoplasm of the cell, and the viral RNA is then translated into proteins, and new virus particles are formed. And these virus particles are released, infecting yet other cells, but can also be ingested by antigen-presenting cells. And these antigen-presenting cells present, especially then again, the spike protein to a T helper cell. The T helper cell can stimulate cytotoxic T cells to destroy infected cells, or they can stimulate B cells to form antibodies directed against virus particles. And in this way, an immune response is produced that is formed by memory B cells and T cells that are created. When talking about vaccines, there are various platforms for vaccines, 7, but for COVID-19 at the moment only 3 are really important. The most important ones I'll explain to you. They are based on injection of proteins or parts of proteins, especially again the spike protein, and that is the basis of the Sanofi vaccine. We've got vaccines in which, again, the spike protein is expressed at the surface of another virus, a non-replicating vector virus, often an adenovirus, and this is then injected, and there's an immune response can be produced against the proteins that are expressed at the outer layer of this adenovirus vector. And the third one that is important are the RNA vaccines. And this is a kind of lipid layer particle with in the center RNA, and this is injected. The lipid layer fuses with the cell membrane. RNA is then released, and that forms a spike protein to which then again an immune response is produced. And these RNA viruses that are completely new. The protein-based vaccines, the viral vector platforms, relatively new, but some experience in clinical practice. The RNA vaccines is something completely new for COVID-19 vaccination. Is there then experience in patients with chronic kidney disease? And I listed that on this slide, looking at all the producers and all the vaccines that are tested in large-scale trials, around 40,000, all parts of the world that they are tested. But when you look at the study protocols and when you look whether patients with CKD stages 4, 5, dialysis or a transplant are included, that's not the case. Only in the Pfizer vaccine, some patients with dialysis and some patients with CKD stages 4, 5 were included, but that number was far too low to allow any conclusion about efficacy and safety in our patients with kidney disease. And that is very unfortunate because we know that due to uremia, but also the use of immunosuppressive agents, there is often less efficacy of vaccines in patients with later stage chronic kidney disease, but also in patients on hemodialysis and kidney transplant recipients. We know that for hepatitis B, we know that, for instance, also for influenza vaccination, but also for pneumococci vaccination. And then to improve immunization, as nephrologists and virologists and vaccine experts, we have sought for all kinds of improvements of immunization efficacy, and various strategies have been investigated, among others changing the injection mode, adding repeat vaccination, but also the use of immunostimulants. And these are lessons that we learned with these other vaccines, but there are now questions also, of course, about the COVID-19 vaccines. Are they effective and are they safe in patients with chronic kidney disease? Are there differences between these different types of vaccines in efficacy and safety in the general population, but also in our patient population? And should the standard vaccination regimens be changed in CKD patients? So a lot of questions remaining, and therefore we thought it very prudent that we would organize a round table. And then I'll hand over to my co-chair, Professor Luuk Hilbrands from Nijmegen, the Netherlands, who will take over the remainder of this e-seminar.
Thank you very much, Ron, for this very clear introduction of the topic. I think that many of the questions that you already mentioned are very important. So I would like to introduce again our panelists. Maybe not all attendees were present at the beginning. So I think you can see the names, but if not, maybe the panelist can raise the hand when I introduce the panelists. So I will start with Marta Crespo. Marta Crespo is transplant nephrologist and head of the transplant unit in Hospital del Mar in Barcelona, Spain. And she has a long-standing experience in kidney transplantation. Piergiorgio Messa is professor of nephrology and director of nephrology, dialysis and renal transplant unit in Milan, Italy. Welcome. Then Professor Marjolein van Egmond She's a professor of immunology in Amsterdam, the Netherlands. Is also the spokeswoman these days of the Dutch Society of Immunology on the topic of COVID-19 vaccination. Then we have Coretta van Leer. Coretta is a virologist in Groningen, but also trained as a pediatrician, and she did a PhD in microbiology in Switzerland. And last but not least, we have Fiona Loud. Welcome. And Fiona is a policy director of the Kidney Care UK. That's a patient organization. She's a representative of the and also has personal experience in kidney disease. So again, welcome all of the panelists. And I think that the two main questions that appeared from the audience and which were sent in was focused on two topics, efficacy and safety. So let's start with efficacy. Maybe Piergiorgio, can you say something about what your feeling is about the efficacy of these vaccines in kidney patients? Can we expect a good response to the vaccine?
Of course, we expect a good response, but this is just hope and hopeless. But we don't know exactly what will happen by vaccination. But we need to start with the vaccination at the same time, since it's the only tool we will have for trying of stopping this pandemic. As Ron before stated very elegantly and very simply, we have already experienced that in our patients past vaccines worked not so much as in the general population. So we could expect that possibly, at least in some of these patients, we will need to increase dosage of this vaccination. Anyway, we will only know this after proving starting a vaccination in our patients. Who needs absolutely to start with this program. So I don't know, and I don't think that nobody of us can give an answer, a complete answer at the present time. But we know that we can start knowing that possibly we shall and must increase the vaccination as the number of dosage possibly, or the doses utilized.
What's your educated guess? The efficacy in the normal population is 95%. What's your educated guess about dialysis patients?
It's difficult to have a forecast, a prediction. I think that we'll have a good chance if we will have around 60-70% of good response. It could be just a good starting point. I don't know if will be the real what we really will find, but I think that's approximately this is what I expect to see.
Yeah, Marta, what's your opinion about kidney transplant patients?
I guess we are assuming and we are guessing from the information that we have got from the general population. As Ron said before, only a few patients with chronic kidney disease or dialysis were included in the AstraZeneca trial, so we don't know any real thing. But when listening to Pepe, I was thinking that we have to distinguish between a clinical efficacy. That's what the two big ones have demonstrated in the literature up to now. So if we are speaking about 90-95%, we are speaking about not acquiring COVID. And but if we go to the placebo group, it's not the opposite. So we have to distinguish between clinical efficacy and immunological efficacy, and we have two experts today. So we need to learn from both sides, because because we are not going to use only the vaccine, we are going to continue with the protective measures. So both of them have to play at the same time, and that's very important that we transmit that, that we have to keep our patients protected, because we don't know yet, and because vaccine is not going to be the only tool that we have to use for now.
Okay, thanks. Marjolein, from an immunological point of view, what do you see as the main limitations of these vaccines in kidney patients, dialysis patients, and transplant patients?
Well, I would think that if patients are on immunosuppressants, then that might hamper efficacy. So that might, I guess, influence the efficacy of the vaccine. Mm-hmm. So that I would consider a challenge.
Yeah. And what do you mean with immunosuppression? Do you mean every type of immunosuppression, or do you think of certain agents that might more strongly suppress the immune response to the vaccine?
Well, of course, anti-B cell, like anti-CD20 antibodies, will definitely hamper the humoral side of the vaccine. So it's not known if you then develop, if the T cell immunity is sufficient. But it's very difficult to say, because many of these questions, it's just so early days. We don't know so many things at the moment. But I would definitely say if people are on like rituximab, that will almost definitely influence the efficacy of the vaccines.
Mm-hmm. And do you know how long the effects of rituximab persists in terms of suppression the immune response?
That's actually quite long. So you have to really withdraw rituximab treatment, I think, for quite a while to get your B cells back to normal. And at this moment, so basically all the advices about the use of the vaccine is we don't know yet anything about patients that have problems with the immune system. So don't do it yet. So that's basically so it can be given to anyone except for the patients that have problems with the either autoimmunity or immunosuppressants or immunodeficiencies, because there is just no data how people will respond.
Mm-hmm. And if we agree that the response will be less in these patients, are there currently any advices or recommendations to change a dosing regimen, for instance, increasing the dose, of increasing the number of vaccines that we...
No, it's really, as I say, it's really early days. So it's like the first clinical trials with, relatively healthy people have been performed, and we know those data, and all those follow-up trials are currently under the way. So there are now follow-up trials with patients that have autoimmunity, and I assume also with immunodeficiency, but at this moment there is nothing known about if you can sort of circumvent problems by changing the doses or the timing or multiple doses. So that's, it's a guess. We don't know yet.
Yeah. And Coretta, from a virological point of view, do you think that this virus can be compared with other viruses of which we have more information so that we can extrapolate data from other vaccinations, or is this a completely different virus?
Well, of course, it's a coronavirus, and there are 4 seasonal coronaviruses that we know very well. As a clinical entity, is a mild cold for most people, which is why no one was really ever interested in developing vaccines against those 4, except that we also have had outbreaks of really pathogenic coronaviruses, like the first SARS outbreak in 2002, 2003. And more recently, MERS. It has certainly been attempted to develop vaccines against MERS, and it hasn't been successful yet, which is a bit of a warning. I mean, not even in healthy individuals, it hasn't been possible to develop an efficient vaccine against MERS, even though MERS has been around for 7-8 years. But I think what all of my previous colleagues are hinting at is there are markers of immunity that you can measure in a lab, like antibodies and T cells, but we have no idea whether they translate yet to really protecting from the infection. And right now, the 2 RNA vaccines, which completely new approach to developing vaccines, we have the most of the data on those 2 vaccines, and they give both lab responses, plus they seem to protect from infection. But we should not forget that those trials are not finished yet. And if I'm optimistic, I would say the first people have been immunized with those vaccines no more than 6 months ago. So for now, it's looking really good. And those people, at least in the first data that came out, it's definitely protecting against the infection, but we have no idea how long this is going to last. And if I have to take my guesstimate on what will be the difference in the transplantation or in the kidney population, I'm going to guess the immunity is going to wear off sooner than in healthy individuals. But this is absolutely something we'll have to investigate. But it is clearly we see in completely other pathogens like hepatitis B vaccination that we do see that most people do have an immune response that we can measure, but it wears off more quickly than in a healthy individual.
Yeah, thank you. I would propose to switch now to some remarks on safety, because in the end, I think we will focus on the balance between the expected advantage and the possible disadvantages of vaccination. So in some patients, we will need to seek this balance. So let's first have a look on the potential adverse effects of vaccination, especially in this population. Piergiorgio, do you foresee any special problems with vaccination in CKD or dialysis patients, or in patients with autoimmune diseases, which might maybe get a flare of their autoimmune disease?
Really, I have not much concern as far as dialysis patients are concerned, since I think that we do not expect some different adverse events in this kind of population from what we read, at least in the trials, in the registered trials. Some possibility is we don't know what really will happen about the cell immunity. So the cell immunity, which is a kind of a T helper, directed cell immunity, could be of some concern, but at least in theory, for transplanted patients, for example. But we really do not know how much these types of, but I think that Marta, Coretta would, and Marjolein would answer this, my personal doubt much better. We don't know how much this is just a specific or a very general and no specific, unspecific response, immunological response, increasing TNF-alpha or interleukins or interferon gamma. So just for possibly inducing a rejection episode. I really do not know how much this is just specific or a not specific response. But for dialysis patients specifically, I have no much concern.
Mm-hmm. And for patients with glomerulonephritis or autoimmune diseases, do you foresee any risk of disease complication?
Yes, I don't think that for these patients should be a very big concern, really, at least for those patients who have mostly a B-related response. So we don't know exactly if this could be a cross reaction, but I don't think so, really. So I have no much concern for this. Anyway, the problems could be in these patients when we are using drugs against B-cell replication and activity. This could be a conflict of interest between the vaccination and the drugs.
Thank you. Marta, do you agree?
Again, it's a guess. What you're asking for, but I am not especially worried about safety, considering the experience that we have with other vaccines, the vaccines that we usually administrate to kidney transplant patients. Of course, we do not administrate attenuated vaccines. So if we think of the ones that we use, like influenza or pneumococcus or even the herpes zoster, the vaccine that was developed not so long ago, safety in general has been not a problem for transplant patients. Then if I try to go to the mechanism, and if I think that this, if we are thinking of the mRNA, which is producing, which is in the end producing the protein, the spike protein, and immunizing. If COVID-19 patients did COVID, I mean by the transplant patient who acquired COVID, who were infected, that we all have gathered in our national registries and then put together in ERACODA, we didn't see rejection, even when we were withdrawing immunosuppression in general, or at least the most potent immunosuppressors. So I wouldn't be worried about rejection. Then there is there is controversy in the literature regarding the production of HLA antibodies. Some studies on influenza vaccines have communicated the production of HLA antibodies. Some others have not, so we don't have a conclusive message from that. But I am not worried about safety.
Mm-hmm. And for the autoimmune diseases, we all know patients that have a flare of their autoimmune disease after an infection or after a vaccination. So could this also happen in these cases?
I don't really know. I was reviewing literature and guidelines and statements from different societies that have been sent to us these days by different friends in the transplant field or in nephrology. And I think it's from the AST, they were recommending that patients in general were stable, were not having a flare, or were not, and were like distant from rejection episode or from treatment, for example, with rituximab or those drugs that we use for specific problems. Apart from that, I cannot say too much.
So production, you mentioned production of the spike protein by the vaccine. It's induced by the mRNA in the vaccine. Binding of the spike protein to ACE2 receptors, could that be, in theory, give any problems?
I mean, that we haven't seen that even in patients with severe COVID, so I wouldn't expect that. Mm-hmm. I'm looking at Coretta to see if she can help me.
Yeah, I do have some data that the spike protein, which is made by infected cells, well, following the vaccines. So when the vaccine, the RNA enters the cells, actually the spike protein is made by myocytes in the arm, and it stays locally. And of course, it will go to regional lymph nodes, but it's not like the spike protein does not divide itself in the rest of the body. So I'm not expecting that kidney cells will actually be infected somehow or affected by spike directly. If there is any relation, then it will have to be immunological.
Mm-hmm. There are also some worries about the use of vaccines that are produced on cells with respect to contamination with remnants of the cells that could express HLA antigens. Any one of you aware of these stories? Piergiorgio, you please use your microphone.
Yes, I don't think we have data to be concerned with this possibility. All is possible in biology, especially with the so unknown virus such this one. Mm-hmm. Since we have learned by our experience in Italy, but I think everywhere, that what's expected was unexpected, and vice versa. And so I don't really know, but it is not expected by a rational point of view, but never say never.
Most information that I got was on the production of the AstraZeneca vaccine on human embryonic kidney cells. And in theory, this could contain HLA molecules, but I heard that in the UK, in a large sample, no HLA antibodies were found. Was that what you would like to say, Coretta, or do you have?
Yeah, it is. It's only a potential issue for those vaccines that use real virus. So that would be the Oxford vaccine. So all the virus vaccine virus vector vaccines that are out there, the RNA vaccines are not produced on cell lines. It's just a biochemical reaction. So that doesn't make any sense. But yeah, the few vaccines that are out there that use cell lines to culture the viruses, so that would include the adenovirus, that's actually the vector for spike protein, that's cultured on human cell line. But it does sound a bit far-fetched that you would actually introduce human DNA in the vaccine. So I kind of like the previous speaker remark about the real effects will come unexpected, the ones you hadn't had a clue about. Yeah.
Well, I think it's not the human DNA that it's in the vaccine, but that are really the remnants of the cell, the proteins, so the HLA proteins. And well, it has been mentioned in another vaccine trial that this could be a problem, that you can immunize patients against these HLA antigens. But the problem seems to be less with with respect to the latest information with the Oxford AstraZeneca vaccine.
Yeah, and with the RNA vaccine, there is no human HLA present in the production. So
Fiona, I think that you would like to add something, and one of the questions that I have for you is if you have heard this as a patient and you hear that there are well, that there's no, we cannot be sure about the efficacy of the vaccine. There might be side effects, although it seems to be a little bit reassuring. So what would be the balance for a patient? When is a patient inclined to get this new vaccine while there is no experience until now in your patient population?
So thank you, Luuk. Yeah, first of all, I mean, kidney patients, as you said very clearly at the beginning, have had a horrible time during the last year, really, and the impact of COVID-19 cannot be underestimated on people like me, but the people who we hear from all the time at the charity as well. So people do see the vaccines, the range of vaccines, as a way out or a path back to some kind of normality, and they have many, many questions, and that is why webinars like this are very welcome, so people can hear those questions and get some opportunity to have honest answers, such as the colleagues here have described today. And the first thing that you've said quite clearly, which we've heard through our local kidney experts as well, is about this balance between safety and efficacy. So the vaccines being safe, being pretty clear, but not 100% clear about how well they're going to work on people who have the difficulties of kidney failure, immunosuppression, and so forth. So the sort of things people would want to know going forward are things like, what is the follow-up going to be? How are we going to collect that information? How are we going to learn? The risk of COVID-19 versus the risk of getting a vaccine. And you talked very clearly about the risk being far enormous, as we know, from COVID-19 versus theoretical risks from any vaccines, but nevertheless important to follow up on that and to share through patient charities such as ours, the work that is doing, the work that the registries are doing. So I know that the European registry is collecting this data, that our UK renal registry is also collecting this data. As an individual, I see, I am very, very keen to be able to access a vaccine, and I trust that the work that is being done, the information that we have been able to understand and share is clear enough that we are actively consenting to something that offers the opportunity to prevent the danger of catching COVID-19. But at the same time, as Marta said earlier, it's about that balance. So we are at a very dangerous time at the moment where infections are going wild here in the UK, and I know they are in other parts of the world as well. And that balance between when we can start to get back to normal and how much protection we need to continue to do. And that is the piece I think we're not quite yet clear on, about where the balance goes. And then the other interesting things about how frequently we have to have the vaccine, can we get our second dose, and what are the rules on that as well. So on balance, most people that we have heard from are, well, they're all interested in the vaccine. They all have lots of questions. Many of them are very keen to access the vaccine, but at the same time, of course, they want to be able to hear that the monitoring is going on, that information is going to be shared, and that over time, as more and more members of the public as well get vaccinated, they'll be able to start to reduce their guard as well, because after a year of going through this, people do want to get back to kind of normality. So I hope that.
Yeah, thank you very much. And on the topic of monitoring and research, we'll come back later on. Coretta, a question for you. If there is a question on the balance between efficacy and safety, would the potential exposure of the patient to COVID-19 play any role in decision making? So if we would have a patient in which we could expect that there might be more risks than in other patients, would it be reasonable to delay vaccination if the expected exposure to the virus is low?
Yeah, that's a really good question. I think currently we don't have that luxury. It may be an issue for when we do achieve a lot of vaccination in our population, and when the incidence hopefully goes down in 2021 for patients who will get that decision later on in the year, it may become a real question. But on the other hand, we will have far more data by then. I think at the moment the danger is so high for kidney patients that I think that will be the biggest argument to get the vaccine, in spite of there not being any long-term data. But yes, there will eventually come a point in time when the chances of actually getting the virus, and there will be countries right now that are experiencing far fewer problems with COVID, where this is a reasonable question. And yeah, maybe in those countries, especially kidney transplant patients who are more worried about the side effects or the more autoimmune driven chronic diseases do have a good point if they want to wait for more evidence to appear.
Mm-hmm. Marta, what are you advising to your patients, or do you advise every patient to get a vaccine, or do you have some patient groups that you advise to wait a little longer until we know a little bit more, or maybe you advise not to take the vaccine because you think that it will not be effective, or that you have concerns about the safety? Do you make any distinctions?
We were discussing this morning as a group, and our agreement is to accept vaccination in any transplant patient, because they are already calling us, except for the first 1 month after kidney transplantation, because probably it makes less sense, the possibility of them to respond to the vaccine. But any patient especially on the waiting list, but also transplant patients, we are advising them that if they are called to get a vaccine, don't hesitate and go and get it. We're going to try to monitor as many as we can, but we won't be able to monitor each patient. It will be impossible to get samples to measure antibodies or cellular responses before and after to every transplant patients, because fortunately they are a lot. So, but we will try to monitor some of them. So if we can, we will do it. If not, we are telling them to, when they get the call from their general practitioner, to accept and go on and get the vaccine. And we're trying to organize vaccination ourselves too. So we are in the middle of this. For the moment, we have vaccines for the residences and the sanitary, the hospital staff or the health staff in general.
Yeah, but some kidney transplant patients may belong to that groups.
To which group, sorry?
The groups that you mentioned, the latest, that are already included in the vaccination program. So
yeah, in fact, in fact, we were speaking this morning about one transplant patient, a very old lady who lives in a residency home, and she was or her family were contacting us, and we said, okay, that's the best thing to get the vaccine.
Yeah. And you mentioned monitoring, and then you meant immunological monitoring, but do you recommend to monitor safety? For example, check creatinine 4 weeks after vaccination or 2 months after vaccination?
We haven't planned that. We what we have to do is to register all the ones that got a vaccine and to have a general interview about safety events. But we cannot do that with like calling every transplant patient daily for 1 week or 2 weeks. That's impossible. So we have to educate them or to share with them how important this is. So they have to tell us if within the first week they had some kind of effect. I guess even if we vaccinate them or if they get the vaccine from the general practitioners, they all will be advised that way. They have to communicate the health system if they have an unexpected event. About creatinine, we were not thinking of changing how to follow them, especially in this moment. We are facing the third wave now. And it's strong, I guess, not only here, from what I hear from the media. So I don't think it's the best moment for them to come more often to get a blood test. So we will try to be conservative in terms of not having them too often in the hospital. So we will monitor closely, like 20, the idea is like 4 weeks after the second dose of the vaccine to have a sample for immunological monitoring. Of course, if we do that, we will add a creatinine and something else like the regular test, but not specifically, or at least I had not thought of that. Maybe you convince me that we have to test all the 800 patients that we are controlling, but that's a lot, and I guess for other centers it will be impossible.
I could imagine that you start with the first series of patients to do that, but I do not have evidence, of course. So Piergiorgio, do you exclude any patients for vaccinations at this moment, or do you recommend it for everyone?
We are just starting with the program of vaccination of all hemodialysis patients, and among patients, transplanted patients, the stabilized one, I mean patients who have been transplanted more than 6 months before, and who have no acute or chronic active rejections. All these patients will be, we will propose, and we are starting with a kind of a monitoring. I agree with Marta. It's impossible to propose an overall coverage of controlling any patients in each patient, but we can choose some specific subgroups of these patients to follow up these patients by an immunological, or in addition to the clinical point of view, just to see thereafter among these who will develop, for example, COVID, or who not, if there was any kind of difference in the extent, the amount, the type of immune response during the period. Of course, this can be done by a protocol in a minor part of all these patients. It is easier in dialysis patients, it is much more complex in transplant patients.
Okay, thank you.
We are planning this.
Yeah, thank you. Ron, would you like to add something?
Yeah, I would like to ask the question a little bit stronger, because you're now stating that people can get vaccines via the transplant center or the dialysis center, and we'll probably choose one specific vaccine which we think has the best efficacy to safety ratio. And in my view, these are RNA vaccines. And when you now state it can also happen that they just get a vaccine by their general practitioner, and it might be that it are the viral vector vaccines. And when it might be a problem that you have those HLA antibodies, should we be not more strict? And should we try to regulate that? And perhaps that's a question to Marjolein. I don't know the answer, but I would prefer one vaccine of which we at this moment think has the best properties.
Yeah, I agree. So I'm not saying one vaccine, because I think there are really only minor differences between the Pfizer and the Moderna vaccines. So I would sort of say just the RNA vaccines. But I agree, up till now, the RNA vaccines seem to have the best papers. So I know it's different in the UK, but in the rest of the EU, we are not even using the AstraZeneca vaccine as of yet, because we have not seen the data. We know from both the RNA vaccines that they have, sort of the healthy population, 95% efficacy, which is much higher than expected. And the current side effects are really limited to what you can expect from any vaccine. So I would also say in terms of safety, so if you know of your patients that they handled other vaccines quite well, then I would also assume, or that they will handle this vaccine quite well. And I agree, it will also make the follow-up much easier, because then if everyone gets different vaccines, then of course it's going to be much more complicated. So I would definitely advocate using RNA vaccines in these patients.
Okay, thank you very much. Other opinions on this issue? If we have the luxury to choose between the different vaccines, it's clear we choose the RNA vaccines, but should we wait with vaccination if someone can get another vaccine earlier?
Could I really quickly comment there, Luke?
Yeah.
Is that okay? Just really quickly. So as was just said, in the UK, we don't have approval of one of those vaccines that was just mentioned, the Moderna one. We have approval for the Pfizer and the AstraZeneca. And the HLA issue that was just discussed has been investigated here. All the papers have been seen, and it is our kidney doctors are advising that either vaccine is appropriate for kidney patients based on the data they have seen and so forth. So I think it's helpful perhaps just to make that clear. The second thing is, as we were talking about the follow-up, I do agree with the sample type approach, because that's much more practical. But the patient education piece is very important too. So our renal registry is proposing a way that patients can actually input themselves that they have had the vaccine as one of the ways of tracking that people have had it, not so much the follow-up of the side effects, but just to propose that people have had it. So I think some patient engagement in the way of letting people do a bit of self-management as well, is important, because people should be able to tell their renal colleagues that they've had it through their primary care, that they've had the vaccine, and be able to feel in control of their own care in that way as well, because we know people have self-management is the way to go where you possibly can. Thank you.
Okay. Well, so some very practical questions that are still remaining. If we agree on vaccination and we have a patient that already had COVID-19, does this patient need a vaccination again? Marjolein, question for you.
Yeah, that's a very difficult one. So at this moment, we just don't know how long people are protected after experiencing a COVID infection. So for now, the advice is that even if patients have had or people have had the infection, and we don't know how long protection lasts, so vaccination is actually recommended. Also because there is no evidence that it will do any harm. In fact, the immune system works that if you give it the booster, you probably get a better immune response. So the advice is, yes, get the vaccination, even if you have experienced COVID-19.
And can measuring IgG titers help you to guide this?
Not really, because we have we don't know really how much IgA titers you need to translate. And in the end, of course, the protection is because of the memory response. So even if your IgG titers have gone down, it might be that you still have memory cells. And so there is no one-to-one correlation. So no, I don't think that will help you, the titers, no.
Mm-hmm. Ron, you had an additional question on this issue?
Yeah, especially on this issue, because we know that there is an impaired immune response in our patients. So when we see that IgG titers go down, would that not be an idea to give them a third shot in case of the vaccines that using 2 shots? It is accepted as the best surrogate, those IgG titers.
I think it's worthwhile considering. Of course, there are also vaccines for other type of pathogens that actually require 3 shots. And as I say, you know, boosting the immune response may actually help to increase, well, to get a better immune response. So I don't know if that's sort of legally allowed, because nowadays, of course, you still have this well, the permission for these 2 shots, but it's definitely something worth considering, yes.
Because many of these experts here are now advising to check their patients, to monitor them, and I guess that they mean monitoring for IgG levels.
You know,
when we are going to monitor them but don't do anything for those IgG levels, either we should not monitor them, or then also have practical consequences tied to it.
You know, but there's a difference between measuring the IgG titers after vaccination, because then you can actually see if it goes up after the first or the second or third boost, or measuring it if you know, like, if patients have had COVID in March, and if you would measure the antibodies now, then it doesn't necessarily mean anything anymore. No, but definitely after vaccination, then of course an increase in the IgG titers will give an answer to whether there is an active immune response.
Okay, so I think the issue of monitoring and repeating the vaccinations has now been answered more or less. There was also a question on combination of different vaccines. Is it a problem to combine the COVID-19 vaccines with other vaccines, for example, the influenza vaccine or other vaccines that we give to our patients? Coretta, is that maybe a question for you also?
Yeah.
Well, at the moment, I think the producers of the new coronavirus vaccines will really reject that thought, because it's impossible to then distinguish side effects that people may experience from any one of them. Immunologically, there's probably not a reason why you that would advise you against it. I think the immune system is more powerful than the one pathogen you get through vaccination. But yeah, it's just hard to say when you get your big arm and your low-grade temperature or whatever side effects you may experience from the vaccine, which one has caused it. And for liability reasons, I know vaccine producers never want you to combine them.
Mm-hmm. Okay, Piergiorgio, you would like to say something on that or not?
Yes, I would like to come back to the previous question of monitoring and deciding according to the IgG levels if these patients could be or not much more prone to develop a second infection. We have had some anecdotal cases of patients who were COVID positive in the first wave and a very serious, and in the second wave again they became positive. It was independent on IgG levels, and the second wave, in the second relapse, all these patients have a very milder form of the disease anyway, independent on the IgG levels they had at the moment of the second infection. So I don't think it's will be very helpful in following them. I think that we must learn much more than what we know nowadays. And possibly we will get a look to the cell immunity, both memory B cells, but also T cells, since we don't know absolutely nothing on this, and we need to collect more data or having some idea.
Yeah, we agree.
More clear.
Another very, Marta, please.
Yeah, I had a question for Marjolein or Coretta. And I think it's a question that you shared with us before, Luuk. Do we know what's the cutoff for efficacy? The cutoff, I mean, of neutralizing antibodies? No. Because I've read papers about these patients develop antibodies, these general antibodies or neutralizing antibodies, but I don't know where's the cutoff. Like for influenza, we had some cutoffs, but for this one, I don't know.
No, as far as I know, there are no defined cutoffs yet. I think it also has to do with the fact that, you know, in different countries or even different institutes, different methods are being used at the moment. So there's just not sufficient data to really have that sort of validated one test that everyone uses and one cutoff. I guess it's just too early. Yeah.
I've a few final questions, practical questions. One small question, maybe also small or short answer, and another question which is really important, I think. The small question is, if we give a vaccination, there's a chance of about 30 to 40% that the patient will get complaints of the after the vaccination, like fever. And how do we know that the patient doesn't have COVID-19 at that moment? Do we have to check all these patients with PCRs to avoid dissemination of COVID-19?
Yes, I think that if in the very early period after vaccination, we cannot expect a protection from COVID. So I think that it's a good thing to have a PCR in the patients with the fever or other symptoms we can shared by both either by vaccination response or COVID infection. We have had also 2 cases of a very early positive PCR in 2 very early vaccinated subjects. There was a medical doctor in
one day maybe the symptoms subside.
Yes, but anyway, there was very mild cases. But one of these had fever, and the other one just some dysgeusia, and which is much more specific of COVID than for vaccination. But fever can be confounded for a vaccine reaction or COVID. But I think that in the very early period, when one has some very specific symptoms, should be tested for PCR, in my opinion.
Coretta, did you also an opinion on this?
I think it's been said by the other speakers.
Okay, well, then, well, there are a lot of questions that cannot be answered in 1 hour, of course, but we are nearly at the end of the hour, and I have one final question, and I think some of you will have an opinion on this. If we have an effective vaccine and we have patients that are scheduled for transplantation, that are on the waiting list for transplantation, should we delay transplantation and should we first vaccinate all these patients before we put them back on the waiting list or before we schedule a transplantation with a living donor? Marta.
That's very tricky. In fact, our general policy now with COVID around is to avoid transplantation in the highest risk patients. So we are not transplanting in general the very old now, and or the highly sensitized, unless they are so highly sensitized that we get an offer that we cannot reject. I hope I was clear. So we are trying not to limit options or opportunities for patients who had been waiting and are included in the highly sensitized Spanish program. But for over 70, and we are not strict, it's not 70-70. Of course, it's 70-71, 72, depending on the patient and the comorbidities. So for all those ones, we are delaying transplantation already. So for those, I believe we need to vaccinate them really quick so we can go back to they are in the waiting list. They were never out, but we are trying not to call them because we've seen that within the last month, we are facing bad numbers again, and the risk for them of morbidity and mortality is too high, because Ron, you were presenting before the data of the whole transplant population, but if we go to over 65, the numbers are really bad, worse than what we were. And then what about living donors? that's very tricky. In fact, we were discussing this morning because we have 2 living donor kidney transplants at the end of January, and we don't have time to vaccinate them. So we were discussing if waiting or not waiting. One couple is very young, so we are less concerned, but still. And the other is a pair exchange, highly sensitized pair exchange. So the discussion is on the table. What do you think?
Well, I think it's a very difficult decision, and you should discuss it with the patient. But Piergiorgio, do you have an opinion on this? And
yes, I think we in our unit will, and in our policy will plan to start from patients on the waiting list, on dialysis on the waiting list, just for this reason. I think that for living donors and the recipients of living donor kidney transplantation, it should be planned very early vaccination also in this. By a reason or the other, our dialysis patients, or why they are on a waiting list for transplantation, or why they are very old, elderly, and fragile, they need to be vaccinated.
Yeah. Finally, Fiona, what's your opinion on this?
Yeah, so I agree. I think if it's a living donation and it can be delayed for the vaccines, that is absolutely the right thing to do. I think that people who are on dialysis and on the transplant waiting list really need to be vaccinated right now, so that they can get the best opportunities to survive well, and to get that transplant. I also think that the healthcare workers need to be equally brought forward if that's not happening in all the countries, so that they can be vaccinated as well and be safe as they treat people. So those are the things that I see there. And very finally, I think I'd like to give a huge thank you to all the healthcare workers across the world for their bravery in treating people during these incredibly difficult times. Thank you.
Okay, thank you very much. Yeah, with this, I would like to thank all the panelists for their participation. I realized that we could not give the answers on all the questions that we have, but at least some questions might have been solved a little bit. And I'm very grateful that you gave your personal opinion on a lot of subjects, and that will really help the discussions in the hospitals and between the professionals in Europe, I think. So I would like to thank you very much for this participation. And I handle now over the microphone to Ron, who will have some final remarks.
Yes, thank you, Luuk. And I also enjoyed the discussion here. And it is clear, I think, that there is some knowledge here, but it's especially expert opinion, and that really research is needed to get more information about efficacy and safety of these various vaccines and what the various vaccination schemes should be. And for that reason, I would like to propose that we should join forces across Europe. And as ERACODA working group, we have set together, and we think there should be research, and we foresee that there will be two types of studies. And I already heard that during the discussion. We foresee that there would be studies looking at the efficacy of COVID-19 vaccines to generate an immune response, so looking at IgG antibodies. But that is a surrogate, and we don't know how good that surrogate is. So there is also a need for a second type of study that will look at the efficacy of COVID-19 vaccines to actually prevent COVID-19 and to look at safety in a real life setting. And a typical example of study one assessing the immune response, and we in the Netherlands have created the RECOVAC consortium, and that is renal patient COVID-19 vaccination, an acronym. And we will perform a study looking at 4 cohorts, CKD stages 4-5, and that is a power analysis on data that we have from literature, 175 patients included, but also include hemo and peritoneal dialysis patients, kidney transplant recipients, and matched healthy controls. These people are then vaccinated, and we will draw blood at specific time points and measure the immune response. And that will be the primary endpoint, the serological response, but perhaps not the best surrogate. We will also measure the neutralizing antibodies perhaps better, and we will also measure T and B cell mediated responses. But we will do that with only one vaccine, and of course more vaccines are entering the arena. There are already 3 in some countries in Europe, but more will follow in very short time. The second type of study, testing efficacy and safety in a real life setting, will be registry data. And then we could make use of national registries of kidney transplant recipients and dialysis patients. These registries already routinely collect patient characteristics. But we then should also have controls to compare efficacy with. And we could, for instance, choose partners of these patients that are vaccinated, or we use a matched sample out of the National Vaccination Registry when we are allowed to do so. And in case of COVID-19 or in case of adverse events, we'll register in ERACODA with a detailed disease and treatment characteristics, and then link ERACODA with those national registries of kidney transplant recipients and dialysis patients, and then look at the endpoint, what is the vaccination coverage rate? Because we are all positive, but when I do my outpatient clinic, I also see a lot of patients that are still a little bit skeptical and have some fear whether they should be vaccinated. So I would like to know what the vaccination coverage rate is. But we can then also look at the incidence of COVID-19 in vaccinated versus non-vaccinated patients, but also compare the incidence of COVID-19 comparing various vaccines with each other, and looking at the incidence of special adverse events that are rare, and for instance, rejection rates. But I think when we want to do such type of research, I think we should join forces across Europe, because study one, looking at the immune response, that's not that difficult type of study, but we should avoid doing in Europe, in each country across Europe, the same underpowered study with the same vaccine, because it was just the first vaccine that entered the arena. We should then test all the vaccines that are available. So we should coordinate that and divide it over various centers. For study two, when we want to look at the efficacy in a real life setting, that then we have power issues. Huge numbers of patients will be needed, and a country of the Netherlands will surely be too small to investigate this. But even countries like Italy, Spain, or the United Kingdom might perhaps be too small. And I think we need international collaboration there with uniform registration of vaccination data and of COVID-19 incidents. And we should use the same definition of COVID-19 incidents during in vaccinated people. So coordination there is preferable. I think we should harmonize. We should all perform studies using a similar protocol, and then we'll be able to combine results and come up with well-powered conclusions in the shortest time period possible. And therefore, I would like to ask you that in case you know of national initiatives, please let us know, and then we can try to harmonize this. Research is not only needed about vaccines, or still the natural course of the disease. For instance, what are long-term outcome data of COVID-19, about functional status, mental status after a COVID-19 vaccination. And in that respect, I would like you to go to the ERACODA website. Please join our consortium. You can propose your own proposals for research. You can have a look at all the publications we have. You can look back to the webinars that we have organized this far. And that brings me to my acknowledgement. I would like to thank you as experts for being present and giving your expert opinion there, and sharing also the evidence base that is already present. And I would also like to thank especially the ERA-EDTA for giving us the opportunity to organize this type of webinars. And from the ERACODA working group, I would like to thank all the members, but also the management team, the International Advisory Board, and the sponsors. And the sponsors of today's webinar was Baxter, and they gave us unrestricted educational grants to make this possible. Once again, I thank you very much, viewers at home, for looking at us, and the experts for being present and sharing their experience. Thank you.